Good evening, everyone. A warm welcome to Blood the Life Savior, a platform where clinical insights meet real world learning and where every case adds to our collective experience. Today is our 18th episode, and we are privileged to collaborate with Fortis Memorial Research Institute, Gurgaon. Today, we have two very interesting rare cases on inherited marrow failure syndromes. And to introduce our course director, as they are our distinguished course directors. We are having two, that is Dr. B. George and Dr. Joseph John. Welcome you, sir, for this 18th episode. Dr. B. George, sir, he is a director and professor, Department of Clinical Hematology, CMC Vellore, and is a clinician scientist with over decades of experience in managing the hematological disorders. He serves as a vice chair of the Asia Africa Australia Advisory Committee for the CIB MTR and has authored more than 296 publications. His contribution includes the developing the national standard conditions protocol for aplastic anemia and pioneers over the 200 haploidentical transplants at CMC Vellore. His expertise in stem cell transplantation and bone marrow failure syndrome continues to set the benchmarks in hematology and hematology care. Further to this, our second course director, Dr. M. Joseph John. Dr. M. Joseph John, he is the professor and head of the Department of Clinical Hematology, CMC Ludhiana, is a visionary academician, and he is the assured director of the of development quality and NABH at CMC with over 60 publications and several national awards, including the ICMR NIIH Oration Award and SKOCH Gold Prize. Dr. John has been instrumental in establishing the clinical hematology and stem cell transplantation. The launch of this first, the DM, he has launched the first DM program in clinical hematology in CMC Ludhiana itself. Under their leadership, Blood the Life Savior continues to be enriching the platform and fostering the medical education and collaborating the learning across the institutions. Now, I request our course director, Dr. Joseph John, to please take it forward the today's session, sir. Over to you, sir.
Thank you, Mr. Chadda. And as you know, this is a program which is concentrating on benign hematology because a lot of malignant hematology discussions are happening. And I'm happy for Dr. Vikas Dua to agree upon doing this case and showcasing some of the rare cases they have for us to learn from this discussion. Dr. Vikas Dua is the principal director and head of pediatric hemato-oncology and BMT as Fortis Hospital. After his MD pediatrics, after MBBS and MD pediatrics from Haryana, he has from PGI Rohtak. He has done his FNB hemato-oncology and subsequently trained in Singapore and in the US. Well accomplished person who is doing almost everything possible in hematology at Gurgaon in Fortis Hospital. And he will introduce his team who will be presenting and discussing the case. Over to you, Dr. Vikas.
Thank you very much, Dr. John and INTAS team for this opportunity. And I think today is your 18th episode. And I sincerely want to thank you for giving Fortis Pediatric Hemong team this opportunity. So, friends, maybe next couple of minutes, we will be starting the two cases which will be discussed by two of our consultants. And the main person who will be taking the discussion forward is our Associate Director, Dr. Sohini Chakrabarti. So let me introduce Dr. Sohini Chakrabarti first. Dr. Sohini is a graduate and a postgraduate of Calcutta Medical College, and she has done her fellowship through national boards from Narayan Hridayalayar, Bangalore, and then she has done her transplant fellowship under Dr. Revati from Apollo Chennai, and she's a part of important, I would say, part of our team for more than 8 years. To present the first case, we'll be having Dr. Vaibhav Chadda. Dr. Vaibhav Chadda is a graduate from Belgaum and then has done his MD Pediatrics from Bangalore Medical College, then went to Mumbai to BJ Wadia Hospital for his FNB, and then has done his fellowship in transplant from Apollo Hospital, New Delhi. The second case would be presented by Dr. Sunisha Arora. Dr. Sunisha Arora is another consultant in our department. We have a team of six pediatric hemong people in Fortis Gurgaon. She'll be discussing the second case, and she's a graduate of Kanpur Medical College, Government Medical College, Kanpur. Did her MD. I'm sorry, she has done her MBBS from Bangalore, from Bangalore, then MD Pediatrics from Government Medical College, Kanpur, then fellowship through national boards from Medanta, the Medicity, and she's a part of our team for last 3 years. So, friends, in next couple of minutes, we'll be discussing the two rare cases of inherited bone marrow failure syndrome. I would say the first case is not that rare, but the presentation is rare. That Dr. Weber is going to tell you. And the second case is actually a very rare case of inherited bone marrow failure syndrome. We all been talking about Fanconi's anemia. We were talking how Dr. Biju George has developed the flu-cy based conditioning for aplastic anemia, and we all are very much familiar with flu with a reduced dose of cyclophosphamide for Fanconi's. But the challenge which we are facing is to how to transplant these two rare or rare presentations with the patient who has got inherited bone marrow failure syndrome in our practice. So without wasting much time, I will ask Dr. Sohini to take the discussion forward so that she can discuss the first case which Dr. Weber is going to talk about, and then Dr. Weber will take it from there. Over to you, Dr. Sohini.
Hello, everyone. I will be inviting now Dr. Vaibhav to please start with his case, following which we'll be having some discussion. Over to you, Dr. Vaibhav.
Sure, ma'am. So, the first case is we are having a 13 years old male child who's a resident of Oman and has presented to us with complaints of congenital heart disease, which was diagnosed at birth and has undergone multiple surgeries for that, and had history of anemia and thrombocytopenia requiring blood and platelet transfusion since past 1 year. So it's a firstborn child out of non-consanguineous marriage with an uneventful antenatal history and was born premature at 7 months of age. So at birth, he was noted to have severe cyanosis and was diagnosed with tetralogy of Fallus and underwent the first surgery at 3 months of age. Since then, he has undergone multiple surgeries. So at first surgery, a central shunt was placed. Then again in 2014, there was a blockage in the shunt and there was a severe regurgitation. So he underwent a conduct repair and a 16 mm conduct was put. Similarly, as the age progressed, he had 3 more surgeries, and in May 2024, a 22 size Hancock bioprosthetic conduct was placed. So the child had presented first time in February 2025, that is at 12 years of age, with episodes of bleeding from the gum and ecchymotic patches. So on CBC, he was found to have thrombocytopenia. He was worked up and a marrow was done, which had shown a hypocellular marrow and marked reduction in megakaryocytes with mild dysmegakaryopoiesis, and other cell line was normal. So he was managed conservatively as the platelet counts were not very low at this point of time. But again, in April 2025, he had come with episodes of bruising. Now, if you look at the CBC over here was only 5,000 platelets, HB of 8.9, WBC 4.1, and ANC of 1.7. So he was having a picture of pancytopenia. When they looked at the PS, there was a marked red cell agglutination, few schistocytes, polychromasia, no blast, and platelets were reduced. So there was some evidence of RBC agglutination, few schistocytes, polychromasia, and the retic was also high. And the DAT came out to be positive with anti-D, anti-C, and anti-JK antibodies. So they thought of some hemolysis happening. Hemolytic workup was done, which was not very significantly positive. They gave a trial of IVIG, which did not show any response with the platelets, and steroids were reduced by the patients, by the attenders. They again repeated a bone marrow in April 25, which had shown a hypocellular marrow with a marked reduction in megakaryocytes, mild dysmegakaryopoiesis, and no blast. So they did workup for MDS. So karyotyping was normal. Basic mutations were negative. AML MDS workup was also done, which was molecular negative at this point. The child was again put on conservative management, and the serial platelet counts were low. He also had low hemoglobin requiring platelet transfusions and blood transfusions. So his platelets were holding between less than 20,000 till May 1425. And on 18th May of 25, he presented with hemoptysis. Bronchoscopy was normal and cardiac cath was done, which had a significant regurgitation and stenosis in the conduct, so which replacement was done. On 29th, a blood test was sent to rule out other causes of thrombocytopenia and a marrow involvement for pancytopenia, in which a Coxella bruneti IgM came out to be positive, and he was diagnosed with query Q fever, which might be causing all these symptoms, and he was put on doxycycline and hydroxychloroquine. They also contemplated whether the conduct which has been placed getting blocked multiple times is responsible for hemolysis and thrombocytopenia or consumption, but that was ruled out at them as the marrow was also showing hypercellularity and dysmegakaryopoiesis. So we had a 12 years old male child who had complex congenital heart disease, undergone multiple surgeries, presenting with bicytopenia, that is anemia and thrombocytopenia, with bleeding manifestation, transfusion dependence, refractory thrombocytopenia, query immune-mediated process undergoing with no response to IVIG because of high retic count and RBC agglutination, bone marrow showing hypercellularity with dysmegakaryopoiesis and no blast, karyotype was normal and Coxella bruneti was positive. So at this point of time, the differential diagnosis was either an inherited marrow failure syndrome, which was presenting with a congenital heart disease along with a marrow failure, a variety of MDS, which has not progressed till now, also presenting as a hypocellular marrow and dysmegakaryopoiesis is there. Some amount of alloimmunization, which has happened because of multiple transfusions, maybe, and a Q fever, which might have triggered some of the thrombocytopenia at this point. So a whole genome sequencing was sent for this patient, and it was came out to be a dyskeratosis congenita, which is having a TRC bar TR mutation, which predisposes to AML and also pulmonary fibrosis and bone marrow failure. And a diagnosis of a telomere biology disorder, which is DKC, was made in this patient. Then he was kept on serial follow-ups from 3rd June 2025 to 20th April 2026, where he had a significant thrombocytopenia and anemia requiring blood and platelet transfusion. There was a CT scan also done to look at pulmonary fibrosis in this patient, which had just shown some bilateral GGOs, which had resolved later on, but there was no fibrosis significantly at this point of time. He was also started on romiplastin, which did not show any response in this patient. So the child was referred to us. So it was a 13 years old male child with TOF, multiple surgeries since 3 months of age, anemia, thrombocytopenia with transfusion dependence and alloimmunization, having a history of Q fever on doxy and hydroxychloroquine with a positive DKC mutation. So with this background, the child was referred to us for a definitive management, that is transplant, with no other complaints. So on examination, the child just had mild pallor. There was no active bleeding at the time. Vitals were normal. His anthropometry, his height was between 3rd to 10th centile, weight was at 10th centile, BMI 25th centile, and head circumference was normal. Head to toe examination just had a sternotomy scar on the chest, and there was no stigmata of inherited marrow failure syndrome. His oral cavity, nail, skin, everything was normal. So in April 26, when he presented, he had pancytopenia, regular viral workup was negative, DCT was 2+ again. His 2D echo had a severe obstruction in the conduct and severe regurgitation with the dilated RA and RV requiring repair again. So again, we did a bone marrow over here, which showed a 25 to 40% cellularity. The erythroid had normal maturation, normoblastic maturation. Myeloids were prominent with sequential maturation still in neutrophils. MEGs were reduced. There were significant dysbiosis with hypolobulated and monolobulated megakaryocytes. We tried to work up for a process of MDS, which did not turn out to be positive. His MDS cytogenetics was negative, stress cytogenetics was negative, and as we do not have an access to telomere length analysis, so that could not be done in this patient. We tried to do workup for this patient for transplant. So we did a workup for a cousin who was a full match, but he had a TNF2 mutation. There was no MUT available, and we tried to do HLA typing with father, which he had a half match, and he was TINF2 negative. In between, he has required multiple platelets and LDPRC transfusions during the course, and his DSA came out to be positive, which is a part of a workup as we are doing it for haplotransplant. So for a severe RA to PA conduct obstruction, he underwent a balloon dilatation, that is RV to PA conduct balloon dilatation was done because a valve could not be placed over here because of the process that he's planned for a transplant in future. So as he was DSA class 1 positive, he underwent 3 cycles of desensitizations with plasma exchange, IVIG, and rituximab, post which his DSA came out to be negative. He still required platelet transfusion in between, and we did coxalabdronity test again, which had a high IgM and IgG, and he was continued on doxy. We did the end organ workup. The pulmonary function test was normal, USG was normal, EGFR normal, fundus is okay, and fibroscan was also normal. So his organ function is normal, and he's now awaiting transplant with his father being a donor. So we have a 13-year-old male child with a DKC, that is TERC mutation, with history of TOF, bicytopenia with hypocellular marrow and dysmegakaryopoiesis with requiring transfusions with aluminization and acute fever. So although the definitive management for this patient is transplant, for which he has been referred. So if we talk about DKC, we know it's a telomerase biology disorder. So telomeres are the one which basically helps in maintaining the life of a cell. So any pathogenesis which is happening in telomere maintenance, telomere repair, or any sheltering complex can cause this disorder. So the inheritance is X-linked, autosomal dominant, and autosomal recessive. So in his family, his father is having 2 wives. So he's only child from his one wife, and other children from the other wife are completely normal. And there is no family history of similar disease or any lung or liver disease in the family. So if you look at the telomere, so this is actually a repeated ends of nucleotide, short repeated nucleotide sequence, which is present at the end of a DNA, which is present in a close configuration at when the cell is resting to prevent the lysis or the degradation of the DNA during a resting cell. So there are 3 components. One is the telomere sheltering complex, in which TIN2 is the main. There is RTEL, CST1, and then there is a telomerase complex, which basically helps in elongation of the telomere. So any dysfunction because of mutation in multiple parts of the telomere complex causes a dysfunction and improper maintenance of the chromosomal length, which causes genomic instability and predisposes to MDS, AML, and cancers, and also aplastic, because the stem cells loses their life. Now, as we're talking about the telomere, the pathogenesis is not able to maintain the length of the telomere. Therefore, if we do a telomere length in these patients, it will be less than 1 centile. So this is one diagnostic criteria. If it is between 10 to 1 centile, then there are other inherited marrow failures which can also have a lot less length of the telomere. So the classical characteristics of DKC that we see is a triad of skin pigmentation, that is a reticular pigmentation, which is seen mostly in the face, in the neck, in the upper part of the chest, the nail dystrophies, and leukoplakia, that is seen in the dorsum and the lateral part of the tongue. So approximately 60 to 80% of the patients are going to have these features of this and start presenting at 5 to 10 years of age, and usually the marrow failure starts at second decade of life. But if you look at our patient, he did not have any features which are affecting, which is included in the diagnostic triad. Other features are eye abnormalities, in which you can have a prominent epiphora or retinal abnormality, which we ruled out in our patient. He did not have. There was teeth were completely normal, did not have any cognitive disability. Pulmonary fibrosis, skin abnormality, skeletal abnormality, short stature, hyperhidrosis, hair loss, early graying, or alopecia is one of the features which was not there. Others are genitourinary tract abnormalities, GI abnormalities, gonadal, intrauterine growth retardation, severe form present with ataxia, with the cerebral hypoplasia, microcephaly, and early presentations, which was not there in our patient. There's a process of anticipation, that is, there'll be a history of, especially in autosomal dominant mutation like TERC, there's a history of initial pulmonary fibrosis in some family member, liver disease in some, and then it presents earlier and earlier in the next generation. That is the process of anticipation seen in this patient, in these diseases. And this is the graph which is showing the age of onset of the presentation depending upon the severity. So if we have a homozygous TERT and CTC1 mutation, they present early with a more severe phenotype as compared to heterozygous TERT and TERT, which present later. And the classical DC presentation comes first, followed by aplastic anemia, MDS, AML, and pulmonary fibrosis usually happen later in life. So if we talk about the management, so there are 2 prongs of management. One is a supportive care or with the androgen therapy, and other is the definitive management by transplant. So if you look at the androgens, they have shown a promising role, as the androgens help in elongation and upregulation of the TERT gene and help in elongation of the telomere length. And that's how they help in increasing the life of the stem cells. So there are multiple drugs like danazol, which have been used and which has been classified as one of the safest drugs to be used in pediatric patients. And there is oxymethylone and nandrolone deconate, which has also been used and with doses as displaced in multiple studies. But we do not know the exact dose which is used because multiple patients, multiple papers have different variable doses. The duration of the therapy is not known when till how long we have to give. And as we know in children, if we give a long-term therapy of androgens, it causes virilization and liver toxicity. And when to taper is also not known for these therapies. Hence, it has been recommended that androgens can be used as a bridge to transplant for those patients so that they can maintain their platelet count and hemoglobin count or hematological response can be maintained in these patients till then. Then this is a summary of multiple studies which have used androgens in the patient of DKCs and how they have seen the responses. So they have seen response in approximately 50 to 60% of the patients have an improvement in the blood count, have increase in the telomere length, and the transfusion requirements come down, but it comes with elevated toxicities of the liver and virilization. So the mortality that happens in this patient is mainly because of bone marrow failure. Hence, now after the androgen therapy, the major thing that is there is the bone marrow transplant, which is a life-saving process for them, especially if they have marrow failure and MDS or AML feature developing later on. But the challenges that we have with transplant is that there are high rates of graft failure, infection rates, and disease-specific complication increases because of the toxicities of the allo conditioning that we give. Now, the DNA of these patients is very sensitive to cellular damage by radiation and alkylating agent. That's another very important challenge. Hence, high doses of radiation and alkylation cannot be given in these patients. So we have to reduce the intensity of the conditioning, exclude alkylators and radiation in them. So the indication of transplant in these patients is usually when they develop a bone marrow failure, that is cytopenia, either in one line or in multiple lines, they become transfusion dependent or they develop an MDS. And the challenges, as we discussed, is that there's inherited sensitivity to radiation and alkylating agents. And there are high rates of graft failure, infections, and pulmonary toxicities post-transplant. So in conditioning, we basically have to avoid myeloablation in these patients as it causes excessive pulmonary and DNA toxicity. So the preferred condition over the period of time, especially in matched and mud donors, for which the maximum data we have is RIC conditioning, in which initially people have used Flumel, alemtuzumab, plus low-dose TBI based, and now majority of them have shifted to Flu-Cy, alemtuzumab plus minus low-dose TBI regimen. And if you talk about the haploidentical approach as we have in our patients, so the data is not much. It is limited to few case reports, and whatever long-term data is there, which is published in larger groups like EBMT or ASBMT, is usually about inherited marrow failures, in which DKC forms a small part. So there are two approaches, and either can be a PTCY or it can be a TCR alpha beta approach. So as we know, the PTCY is going to be more toxic because of high alkylation. Hence, it has been recommended that we remove cyclophosphamide from before infusing the graft to add day plus 450 mg per kg PTCY can be given. So they give a fludarabine, ATG or alemtuzumab plus TBI, followed by a 50 milligram of PTCY at day 4. This is one approach. And second is this TCR alpha beta depletion with Flu-Cy, alemtuzumab, and low dose TBI. So the dose of cyclophosphamide and the conditioning that we follow here is just like Fanconies, in which we use around 160 to 200 milligram of fludarabine, 30 to 40 milligram per kg of cyclophosphamide, and ATG alemtuzumab dose is a higher dose usually. So we use an ATG dose of 10 milligrams per kg in these patients. The GVHD prophylaxis is either MMF plus tacrolimus or cyclosporin, and alemtuzumab is preferred usually as it has low incidence of GVHD and PTLD. The majority of the donors of the studies have used a match sibling donor, and it has shown a better outcome as compared to alternative donors in the literature, that is 74% versus 39%. And the graft source which have been used initially is the bone marrow. And in the latest studies, there has been no difference in between the graft source of bone marrow and peripheral blood. So nowadays, peripheral blood is preferred more as compared to marrow. But if you look at the survival data in these patients, there are not many studies which are telling about the long-term overall survival. Few studies which have reported is that at 3 to 5 years of survival post-transplant, it's around 50 to 60%. But as the age progresses, that is till 10 years of age, the survival usually declines to around 23% in these patients, even post-transplant. The outcomes for match sibling donor, best outcomes at 5 years of age is 74%. And if you look at the Rick versus Mac, so it is 66% in Rick versus 40% in Mac. So hence Rick is strongly favored. Age of the transplant is another important prognostic indicator, in which if it is done at less than 20 years of age, the outcomes are better as compared to done after 20 years of age. The main cause of death in this patient post-transplant is infections, followed by pulmonary disease, and then non-engraftment. And specifically in RIC conditioning, the infection predominate, and then the MAC conditioning, the pulmonary disease and non-engraftment predominates. So the poor prognostic factor for this patient is age more than 20 years, alternate donors using myeloablative conditioning and cyclophosphamide only conditioning in these patients. So other than transplant, there are a few emerging therapies with no clinical trial, but this is just theoretical, that we have a PAP D5 bar 7 inhibitors, which have shown to increase the length of the telomere in the mouse models where they have taken the stem cells from DKT mutated mouse, DKC1 mutated mouse, and then they have given these, like they have done PAP D5 knockout, and then they have seen that the telomere length improve. However, there is no clinical trial till now. Other people have used TPO agonist, gene therapy, and supportive immunoglobulin therapy, but TPO agonists have not worked well. Gene therapy is very challenging because there is a very short telomere limit, and ex vivo expansion of the corrected cell is a challenge in these patients. Now, after transplant, if we talk about the long-term follow-up, these patients are very much at risk of developing long-term toxicity, specifically in lung and liver. Hence, a meticulous follow-up of the organ function post-transplant is very important. Hence, pulmonary function, hepatic function has to be monitored every 6 to 12 months. Endocrine, cardiac, renal, oral, and dental. So oral, dental, and skin function have to be seen because they are more risk of developing secondary malignancies, specifically squamous cell carcinomas they can develop later on. And similarly, ophthalmological examination has to be done annually. Bone health, fertility, reproduction has to be checked annually. Immune reconstitution and immunization, that is usually done 6 to 12 months post-transplant. And very important is psychological and neurocognitive counseling and evaluation also has to be done annually, along with lifelong malignancy surveillance. So now I'd like Dr. Sohini to discuss about the further strategies for this patient that we had adopted.
Yeah. So thank you, Vaibhav, for this very interesting case presentation. And I would just like to highlight a few salient points or a few salient take-home messages from this case that I think we learned. So the first and foremost, the most important thing is that NGS is now almost mandatory when we're evaluating a child with aplastic anemia. Many a time, as even in this case, the child will not be having a a suggestive family history, or the child will not be having any physical stigmata. So at the first onset, it will look like a acquired aplastic anemia, but later on, when we actually do the NGS, we are able to find out that this is an inherited bone marrow failure. It is, as we all know, it's very, very crucial to differentiate between acquired aplastic anemia and inherited bone marrow failure syndrome, because then only we will determine what is the treatment plan that we will give to the patient, whether immunosuppressive therapy is at all an option, or we will have to go in for a stem cell transplant. It will help us choose the donor, because having a matched sibling is not enough. We'll also have to make sure that the donor is negative for the mutation. As in this case, his cousin was actually a full match, but when they tested him for the mutation, he was mutation positive, and hence he was ruled out. And this patient has actually been planned for a haploidentical donor transplant. It will help us decide what is the conditioning we'll use and how are we going to prognosticate the patient. What are the long-term complications that we will need to counsel the family for. Many often in dyskeratosis congenita, the patient presents with bone marrow failure earlier and later on may actually develop the physical stigmata. Then the second point here is what is the conditioning that we will choose. Unlike Fanconi anemia, there is not much data about haploidentical transplant in dyskeratosis congenita, but whatever data is there is majority has been extrapolated from Fanconi anemia, and hence that is the strategy that we have also planned, whatever we are doing for our Fanconi anemia patients. So we'll be giving them a fludarabine cyclophosphamide ATG with a very low dose TBI based conditioning. And we have decided we'll opt for the TCR alpha beta depleted strategy, because as majority of you who have seen a Fanconi anemia patient undergoing a PTCY approach transplant, they have very very significant mucositis, and the TRM is very very high. So at our center, we've actually moved on to TCR alpha beta depleted transplants for all our Fanconi patients who are undergoing haplotransplants, and that is the same strategy we will follow here as well. And definitely, we'll have to make sure that we'll have to try and limit the dose of radiation that we use and the dose of the alkylating agents that we use. So the conditioning has to be accordingly selected so that the long-term complications can be minimized. So I would like to ask Joseph John, sir, sir, what has been your experience? Have you had such a case, and will your approach be also similar?
So at CMC Vellore, when I was getting trained at that time, we had a few patients there. We have had only experience with Fanconi transplants here. As you understand and likely said, there is very less number of cases who will be diagnosed, and I'm extremely happy the way Vaibhav has shown the history from the beginning till now. And yeah, I mean, I'm not here to give you expert advice here, but just elicit some discussion so that we will have some consensus on what is it. I agree with your strategy of the alpha beta depletion because we can avoid the PTCY completely there. And just a few queries from my side. The ATG 10 mg per kg is lymphocyte based. Uh, the the Bolen based the kind of therapy they use based upon the lymphocyte count, or it is a standard ATG 10 mg per kg which you're using. So when you use, and my question is, why are you not using rabbit and why do you choose equine here?
So, Dr. Joseph, we are using rabbit. We are not using equine.
Mhm.
So the the ATG what we are going to use for this patient is thymoglobin. The rabbit one,
Hemoglobin.
yeah,
Okay.
10 milligram per kg. In our
So
practice,
over
when it
3 to
comes
4 days. How many days?
over 4 days, 2.5 milligram per kg over 4 days. That's what we are going to do. What we
In,
have been doing for all other benign conditions is that for thalassemia, sickle cell, haplos, we've been using 4.5 milligram per kg of thymoglobin.
correct.
And
Correct.
for our leukemias, we use a very low dose, which is 2.5 milligram per kg. For
Correct.
ALLs, AMLs, 2.5. For our
Hmm.
THALs, sickle, we use 4.5. But specifically for Fanconi's, because we
Mhm.
are going to use a T cell depleted technique, we are worried with the T cell mediated rejections in this patient. So that's why we are using a 10 milligram per kg of thymoglobin. And that's what many centers, if we see, there's a publication by Dr. Parinda Mehta in which she has avoided radiation. So she has used flu psi with 10 milligram per kg of thymoglobin and has added low dose of busulfan. So majority of the publications when it comes to TCR alpha beta depletion for Fanconi's and in journal about inherited bone marrow failure syndrome, they have used either thymoglobin 10 milligram per kg or grapholon at around, I think, 40 milligram per kg.
Correct. So the choice between any experience with Graphlon, because that's something which we were thinking whether to use in alpha beta depletion to bring in Graphlon instead of ATG, because it might linger around there and we may have a rejection worry
So
subsequently. What is your
yes, yes. So we have used, I would say, grapholon for two of our Fanconi's patients in the past. Somehow both had rejection, both rejected. So I am not very sure whether the dose was lower what we use for those patients, or is it because our choice or experience with grapholon was not that much what we
not
have.
great? Okay.
Yeah, so
Sure.
somehow
You,
we are very much comfortable with thymoglobin, so we decided to use thymoglobin. Yeah.
so when will you be bringing in the thymoglobulin? Distal to infusion or proximal to the infusion? I mean, the
So
-9 onwards.
yeah, Vaibhav, can you just share the exact protocol if you have with Dr. Joseph or Dr. Sohini, if you can tell, because you were the one who was
Yeah.
preparing the protocol.
Yeah. So in this, the thymoglobulin is going to basically come on day -4, day -3, day -2, and day -1.
So you would have this ATG lying there for some more time post infusion, considering the longer half-life
Yes.
of thymoglobin.
Yes.
Okay, so
Yes.
I mean, any reason why that? Because I'm trying to learn from you in this, because My understanding was to use it distal to the infusion so that you want to use it as an anti-rejection method, but not as an anti-GVHD.
Sorry, that's right. I think distal is a journal dictum that distal you use as a rejection method and proximal you use as a GVHD preventive
Yes.
method. But what when we were discussing about the conditioning to be used for dyskeratosis congenita, we were actually looking at the literature of dyskeratosis congenita with TCR alpha beta depletion and T cell depletion of pancreas. And what people have done is that they have used proximal, and they have not seen any of the majority of people, and majority of the publications have not shown even a single rejection. So we just blindly
Okay,
followed that.
good.
Yeah. And
So,
we have used a similar conditioning for quite a number of our fan crees. It's not that we are
is
using
it?
it for the first time, and it's not that
Okay, that's
we are
nice to
just
hear.
experimenting. We have done for quite a number of patients, and we have had fantastic outcomes.
Great. And, in the history, Vibha mentioned about the DCT positivity. In the early stage, he had some bleeding issue. I mean, the hemolysis, right? Was
Yes.
it a DAT positive or a allo positive or a allo immunity or is it autoimmunity at
No.
that point?
He was not DCT positive. He has so DSA positivity was there. DSA. So we had to
I thought DAT was
sensitize. We are
positive,
planning to.
anti D, anti C, anti JKA.
Yes,
So that
antibodies
must be.
against RBCs. Yes, yes, sir.
Oh, I'm not
Okay.
very sure. Web. I'm not very sure. Whether you can tell about that.
Yeah, no. I'm just thinking, how do you, I mean, is it still positive or how are you going to overcome that or the plex and your strategy of the DSA desensitization work there also? I don't know.
Sir, so we
Uh,
are basically, yeah. So we
no,
are
no, please, yeah.
basically,
No problem. One of you, please say no issues.
so Ini ma'am can tell.
No, so I was just saying that basically when this patient was referred to us, so the treating team who was treating them earlier had actually found out that this child had got allo immunized, and
Mhm.
but when we have evaluated the child here, so our DCT here is actually negative, and whenever we have transfused, also we have not really had any issue. So basically, so probably it was
Right
something
now.
transient that had happened, but currently he is okay because
Yeah,
the DCT it is negative. Yeah.
absolutely. That's why I don't remember this, Dr. Joseph, because
Yeah.
we have
Yeah,
not
no
had any
issues.
issues. Yeah.
Yeah.
No, this is a very complex case. You guys have done a fantastic job in getting the each and every item and even planning ahead to overcome the lung GVHD issue if it happens. These are all problems which will happen. Now, liver-wise, is he okay? Because some of these patients can have cirrhosis there, and later you may confuse with the skin manifestations as a,
Absolutely,
DKC-related skin
absolutely.
issue,
So
or it's a GVHD skin.
we have already done a fibro scan. The liver enzymes are okay. The liver functions are okay. The fibro scan is fine. So liver is absolutely okay.
And heart-wise is clean. I mean, we have done a ballooning, and he had probably Eisenmenger, right? Because
Yes, yes,
RARB was dilated, and that you got reversed now.
correct. So we have done that, and ballooning has been done. The heart is functioning well, and his EF is okay. The cardiac person has given the clearance that we can proceed for the transplant.
So, is there a recommendation for infective endocarditis prophylaxis here, or you don't have to worry about that?
I am not very sure. Sohini, is there anything from the cardiac side on that? I don't think so.
No, nothing
No,
from their
there's no
side as
valve
of now.
there.
Yeah.
There is no
Yes.
prosthesis there. There
Yes.
is no regurgitation there right now, so it should be fine. I mean, this is almost like taking off on a flight, and I mean, there, before takeoff, you have to do so many checks. Okay, so I'm not seeing any questions in the chat, and we have already taken 40 minutes in this, and it's a huge case. You can discuss from presentation to nuances of conditioning to transplant. So I think we will wind it up here since there are no more discussions there. We'll go to the next case.
So for the next phase, I think I can invite Dr. Sunisha Arora. I've already introduced Dr. Sunisha. She's a consultant in our department, and she will be discussing the next interesting case of inherited bone marrow failure syndrome, which is in many a time, which many a times is associated with immunodeficiencies also. So over to you, Sunisha. You can discuss your case.
Thank you, sir. And I welcome everyone for this discussion. So this is the second case which I'll be presenting. So this will be the order of the presentation. We'll have a case presentation followed by review of literature and little discussion. So it's a case of 5-year-old female of African descent. She was born to non-consanguineous parents and she had complaints of episodic epistaxis from the last 2 years and a low platelet count, ranging from 40,000 to 60,000, but never requiring platelet transfusion. And there was no history of fever, recurrent infections, or significant drug exposure. She was referred to our center for further management. Family history was significant because there was a death of elder sibling at age of 4 years due to an intracranial hemorrhage following severe thrombocytopenia. And also there is a second female child who is 7 years and healthy. So on examination, this was her physical appearance. She had small head circumference, microcephaly. There was a triangular face, hyperpigmentation, short stature, high forehead, low set ears, and a micrognathia. And features like capsular spots, nail dystrophy, and short neck were present. So it looks like features suggestive of Fanconi anemia. So during investigations, we found out that the serial CBC shows a normal hemoglobin trend ranging from 11.5 to somewhere 12.5, WBC count ranging from 4,000 to 5,000 with a fair number of neutrophils, but the platelet count were always low, between 35 to 40,000. Bone marrow biopsy showed overall cellularity of 50 to 55%, but no significant dysmegakaryopoiesis was seen and there were adequate myeloids. So we did a lymphocyte subset and immunoglobulin profile, which came out to be normal. And AML, MDS, NGS was also done because inherited bone marrow failure syndrome can be associated with underlying myeloid process or MDS, but it came out to be negative. And on whole exome sequencing, there was a compound heterozygous mutation in ligase 4 gene, and which was pathogenic. And there was also a heterozygous mutation of VUS in BRIP1 gene, which was Fanconi anemia. So the diagnosis were ligase 4 syndrome. So just to discuss about ligase 4 deficiency, because it's a rare inherited bone marrow failure syndrome, it is located on chromosome 13q, and it is a protein which encodes a key component in NHEJ pathway, that is non-homologous end joining pathway for DNA double strand break repair system. So these are the physical manifestations which can be seen in this syndrome. These are somewhat like Fanconi anemia. There can be microcephaly growth restriction, Seckel syndrome like facies or birth-like facies, hypogonadism, bone abnormalities like bone hypoplasia, syndactyly, polydactyly, hip dysplasias, photosensitivity, psoriasis, eczema, hypopigmentation or hyperpigmentation. And also it can present with immunodeficiency and autoimmunity as well. So it can have varied presentation ranging from combined immunodeficiency, autoimmunity to hypogammaglobulinemia, and may present with severe forms like SCID and Omen syndrome also. And it can also have malignancy in the spectrum because of the defective DNA DSB repair. It can present with substantial risk for mutagenesis and development of malignancy later on. So in the review of literature, I could find only 6 LIG4 deficiency patient who were reported in the literature and presented with malignancy. 5 had lymphoma and 1 had squamous cell carcinoma, in which the malignancy was in the initial presenting symptom, later on found to be LIG4 deficient. So as we have seen the spectrum, there is a lot of difference between the genotype and the phenotype. So it has a broad clinical presentation and it can range from asymptomatic patient to mild cytopenias, and also in the severe form like SCID and Omen syndrome. This depends on the truncating mutation. Where is the mutation occurring at the gene level? So the early truncating mutations can cause addition of an early stop codon that produces the shortest of the protein, resulting in the more severe phenotypes. So the treatment is largely supportive. Hematological support of the marrow hypoplasia by blood and platelet transfusions, long-term antibiotic, antiviral, and antifungal prophylaxis, immunoglobulin substitution, exposure to ionizing radiation should be avoided. And transplant is the only curative treatment which is available for this condition. So I'll just discuss in short about the review of literature about transplant in Lig4 deficiency. So according to EBMT ESID working party guidelines for stem cell transplant in inborn error of immunity, they have suggested for 6 conditioning regimens which can be used in these inborn error of immunity. So what they say about radiosensitivity disorders like DNA ligase 4 deficiency, Serunus XLF deficiency, or Nijman-Briquet syndrome, that the transplant in these conditions should be set on only on case-to-case basis after careful consideration of risk and benefit. And also they recommend using protocol F for transplant. Protocol F constitutes fludarabine 30 mg per meter square for 4 days, cyclophosphamide 5 mg per kg for 4 days, and addition of alemtuzumab in alternate donor transplants. So this is another case series of 3 patients who had LIG4 deficiency. 2 received match-related donor transplant and 1 received a haplotransplant. And the conditioning was a RIC conditioning of fludarabine 180 mg per meter square, cyclophosphamide of 40 mg per kg, alemtuzumab, and with addition of busulfan for alternate donor transplants. All the patients engrafted successfully. They had full donor chimerism and GVHD was not observed in any of the patients. So they concluded that RIC transplant conditioning regimens are safe and effective in this condition. And another case of 2 patients, both were siblings. One received transplant of by using a conditioning and rejected. Later on, received a reconditioning and engrafted. And another case of a sibling who did not undergo a transplant and ultimately died. So this is another case series, which is the largest data which I could find from 38 centers. And it is a review of literature in which they have included criteria for transplant in these patients. And they have defined the inclusion criteria as any infection which is severe or recurrent, any malignancy or bone marrow failure requiring transfusions, autoimmunity, and also preemptive if the features are suggestive of SCID. So conditioning regimens used in this paper, they are defined as MAC regimen, any regimen using a high dose alkylating agent or TBI at any dose. RIC, if they are using, if they're not using any alkylating agent, or if they're using fludarabine less than 150 mg per meter square or cyclophosphamide less than 40 mg per kg. And also they have defined a modified Fanconi regimen, which is similar to as quoted by Dr. Vikas in the Parinda Mehta's paper. That is a fludarabine, cyclophosphamide with or without ATG alemtuzumab, or fludarabine, busulfan, and cyclophosphamide. So there were total 87 cases in this paper, and LIG4 deficiency, there were 36 patients. Most common indication for transplant was repeated infections followed by malignancy and bone marrow failure. 13 patients were transplanted preemptively on the basis of SCID-like diagnosis, and 10 out of them were LIG4 deficient. 22 patients received MAC conditioning and 39 received RIC conditioning. So overall survival was 69%. Survival for MAC, patients who received MAC conditioning was 41 and patients who received RIC was 79. There was no significant difference in transplant-related mortality between those who received modified Fanconi or any other RIC conditioning. And also there was no difference in survival between the donor source, whether it was a sibling, matched, unrelated, or a haplodonor. So the main complications were acute GVHD, which was seen in 49%, and grade 3, grade 4 was seen in 37%. Rates of acute GVHD were lower in the RIG group. Viral reactivations happened in 30% and chronic GVHD in 18%. And a point to be noted was that the patient who received RIC were less likely to develop severe mucositis, VOD, or PTLD than those who received MAC conditioning. So this was the limited review of literature which I could find on this rare topic. So I would like Dr. Sohini to discuss about the further points.
Thank you, Sunisha, for highlighting this case. So I think LIG4 is definitely one of the very rare inherited bone marrow failure syndromes. Now that we have started doing NGS for each and every case, I think often we get reports where these very rare kind of mutations are present, and now there is more and more data that is coming up about this rare variety of inherited bone marrow failure. So if we talk about what are the indications of transplant in a patient with inherited bone marrow failure in general, so as has been highlighted earlier, so the presence of transfusion dependency or the occurrence of high risk cytogenetic abnormalities, or if the patient develops MDS or AML, these in general are the indications when we should take up a patient with inherited bone marrow failure, we should counsel them for transplant. Particularly for LIG4 deficiency, sometimes these patients may present with as a PID rather than a bone marrow failure, and hence history of recurrent infections would be also one of the criteria when we should advise the family to proceed ahead with a transplant. As our patient did not fulfill any of the criteria, she was not having any history of infections and neither was she transfusion dependent, and the bone marrow was not showing any cytogenetic abnormality. Hence, we have counseled the family not to proceed ahead with transplant right now. We've advised them for a close surveillance, and as and when she fits into any of the indications, we have counseled that the family should proceed ahead with the transplant. And as we talk about the conditioning regimen, definitely there is very limited literature. But I think if we have to choose one, probably the modified Fanconi anemia conditioning is what we will be preferring. I think because whatever limited literature we have, I think the outcomes. So what we know for clear is that we'll have to choose a RIG conditioning, and probably a modified Fanconi anemia kind of conditioning will be the way to go uh, forward.
Thank
So
you.
thank
So
you,
yeah,
Sunisha and Sony. Yeah, over to Dr. Vikas. Anything to be added?
no, nothing, Dr. Joseph. I think the point what everybody needs to understand, and I'm pretty sure there are quite a number of students also who are listening to us, that not each
Yes.
and every inherited bone marrow failure syndrome requires a transplant. You need to
Yeah.
follow the stringent criteria. You may be having a inherited bone marrow failure syndrome whose marrow cellularity is not severely aplastic, or it doesn't have a cellularity less than 25%, might not be requiring transplant. So you can just observe. And but the surveillance is very important. You need to keep a close watch. You need to follow stringent protocols. You need to do an annual marrow to see whether that patient is developing a clonal thing or not. Because the point the patient develops a clonal evaluation, you need to transplant them early. That's something which everybody needs to understand. And secondly, what Dr. Weber was talking about, the thing which all of us need to understand is that not each and every patient of inherited bone marrow failure syndrome will have a physical stigmata. You may see patients who would be looking normal to you. So don't just rely on stress cytogenetics only. Do a NGS in each and every case who comes to you with a diagnosis of hypocellular marrow or a aplastic anemia.
Okay. So a few queries. We have only 6 more minutes to go. So before that, a few queries. One is, I understand that you picked up this ligase on a whole genome sequencing because you had a high suspicion there. Was is IBMF panel usually which is done cover this ligase also or no?
I don't think so. I don't think so. The inherited bone marrow failure syndrome panel covers LIG4 deficiency, something which is very rare, because the girl doesn't had a positive stress cytogenetics and was having some peculiar faces which was fitting into LIG4. We planned that we will do a whole whole genome sequencing in this case rather
Whole
than just
genome was done. Yeah.
yes, yeah.
Yeah, so that's a key, Well, so high index of suspicion clinically should drive that because stress may be falsely negative in patients who have had mosaicism. That's
Correct.
another thing we must understand.
Absolutely.
Fanconi can have a mosaicism and stress can come negative, and therefore the genomic diagnosis become extremely important. And then when you was discussing or evaluating the bioinformatics team, that you were worried about these, or how did they zoom into ligase? Because it's not easy. It's not easy for the bioinformatics team also to pick up something so rare.
So I think the initial workup was, see, the girl is from Zambian descent, and a stress cytogenetics was done in the home country. Nothing came positive in that. Inherited bone marrow failure syndrome panel was done back in the home country, and nothing significant was there in that except for a heterozygous mutation for Fanconi's, and that too was also VUS. So we thought, are we dealing with something else? Is there something which is not a classical inherited bone marrow failure syndrome? So we looked at the girl again. One of our junior colleague put in 1 to 10 that these are the physical deformity which this girl has. Then we put that into a Google search what this could be. So it said that this could be LIG4. So then eventually we decided we'll go for a whole
Okay,
genome
good.
rather than just beating behind the bush and thinking that this is the idiopathic aplastic or something else.
Wonderful. I mean, I think that is something which the audience who are here, especially students, should take home. Consultants may not have the answer always, and it is important for you to do Google search, ChatGPT search, write down all the possible abnormalities. And I'm sure the person who looked at it must have, I don't know who that is it Sunisha or somebody else, who has spent enough hours to actually pondering over it to find out, isn't
Yeah,
it?
so we have a fellowship through National Boards program over here, Dr. Joseph, and one of our fellow did the whole exercise.
Hmm. Fantastic. That's great. So, since we are short of time, and I think one question came up, from Dr. Bhavani. If IBMFS presents with MDS with IB1, IB2, then taking up transplant with MAC conditioning versus treating MDS, then using RIC conditioning, which is better? Can anyone elaborate on this? So MAC versus RIC in an MDS in any of these IBMFS situations.
Yeah, so in our experience, those patients who have got MDS, whether you have underlying inherited bone marrow failure syndrome or it's a de novo MDS, we prefer a myeloablative conditioning in our practice. And that's what the literature has also shown. The outcomes are better with a myeloablative conditioning rather than doing a RIC transplant.
Great. So I think we have only 2 more minutes left, and I'm happy to see the full team, including Dr. Rahul Bhargava there and the entire team there. Wonderful to have you, FMRI team, with us to discuss this. And I would hand over to Deeksha Gelot to winding up. And thank you so much. Deeksha, are you there? Or any of the INTAS team is there to uh, say the last comments, and we can wind up this discussion.
Thank you, Joseph John, sir, for having us here, and thank you, Team Mentas, for giving us this opportunity. As a center, we feel obliged. Thank you so much.
Thank you. So I think support team, anybody from Mintas is there? If not there, I think it is 17 and 19:59, and I think dinner time is approaching, and I think we must all go for dinner. And thank you, team, and all of you did a good job, Dr. Vaibhav, Dr. Sunisha, Dr. Sohini, and thank you, Dr. Vikas, for coordinating this. Yeah, I can see Arun Chadda now.
Yes, sir.
Over to
Yes, sir.
Arun
I'm
for
here,
the
sir.
concluding remarks.
Thank you.
Okay.
Thank you. Thanks to all of you, sir. And as we concluded the 18th episode of the Blood, the Life Savior, I, Arun Chadha, Senior Vice President in TAS on behalf of Intas Pharmaceutical, wish to offer our most profound thanks to the esteemed team from Fortis Memorial Research Institute, Gurgaon, and our sincere appreciation goes to Dr. Vaibhav Chadha and Dr. Sunisha Arora for their excellent case presentation. And we also extend a special thanks to Dr. Sohini Chakravarti, Additional Director, Fortis Gurgaon, Pediatric Hematology, for a discussion and moderation that added the immense depth to our session. And thanks to Dr. Vikas Dua, the Principal Director and the Head Fortis Gurgaon, Pediatric and Hematology, Oncology and BMT. Thank you for your insightful summary and for sharing the today's session so effectively. We also remain deeply grateful to our course director, Dr. Biju George and Dr. M. Joseph John, for their unwavering guidance in shaping this initiative. Finally, thank you to all our participants for joining the today's session, and we look forward to seeing you at our next session. Thank you and have a wonderful evening. Thank you, sir. Thank you very much.
Right.
Thank you.
Right.
Thank you, Ji. Thank you.